All right, get ready to spin into this week's deep dive. We're tackling a topic that can make anyone feel a little wobbly vertigo.
You got that right. It's a symptom that can really throw you for a loop.
We've gotten a ton of requests to cover vertigo, so let's get right to it. We've got a stack of material here, and it looks like you guys are really eager to get a handle on this.
I can see why. Vertigo is tricky, right? Because it's not a diagnosis on its own. It's a sign that something else is up.
Like a clue. A
Got it?
clue that can lead to all sorts of different diagnoses.
Exactly. And those diagnoses can range from totally benign to, well, kind of scary.
That's what makes it so challenging. So first things first, I noticed in these materials that we need to be super clear on whether a patient is actually experiencing vertigo or just, dizziness in general.
Absolutely. Vertigo is that distinct feeling that the room is spinning around you or like you're spinning. But dizziness, well, dizziness is a broader term right now.
Like feeling faint or lightheaded.
Exactly. Those are all types of dizziness, but they're not the same as true vertigo. That's why that initial conversation with the patient is so important. We have to pinpoint exactly what they're feeling.
Okay, so making sure we're dealing with true vertigo, that's step one. Now, something else that caught my eye was this fascinating point about the duration of the episodes.
Ah, yes. The tempo of the vertigo, it can tell us so much.
It seems like knowing how long the vertigo lasts can be a major clue, right?
Oh, absolutely. Imagine this. A patient comes in and says, every time I roll over in bed, I get this sudden burst of spinning, but it only lasts a few seconds. What pops into your mind?
With those quick positional triggers, I'd be thinking benign paroxysmal positional vertigo or BPPV.
You got it. That classic story pretty much screams BPPV. But now, let's switch gears. What if someone describes vertigo that hangs around for hours, maybe even with some nausea and ringing in their ears?
Okay, now things are getting more complex. Longer episodes like that make me think about Meniere's disease or possibly a migraine variant.
Excellent thinking. You're picking up on the patterns here. And here's where it gets even more interesting. What if the vertigo lingers for days, even weeks?
Wow, yeah, that's concerning.
That's when the alarm bells really start going off. We need to consider some more serious possibilities then, like a stroke, multiple sclerosis, or even a tumor in the brain that's affecting balance.
Okay, so we've got seconds pointing to BPPV, hours making us think Meniere's or migraine, and days raising some serious red flags. Is there a way to remember this? I'm already feeling a little overwhelmed.
There is. I love a good mnemonic. Think of it this way. Seconds, BPPV, minutes to hours, migraine or Meniere, days, danger. A little silly, but it might help those time frames stick.
I love it. Seconds BPPV, minutes to hours migraine, or Meniere's days danger. I'm definitely writing that down.
Yeah.
So we've got the timeline down. What else can help us crack the code of someone's vertigo?
Well, think of it like a detective case. You look for clues, right? In the case of vertigo, those clues often lie in what makes the spinning worse, the triggers.
Okay, so asking about triggers is like searching for those telltale signs. What kind of things should I be asking about specifically?
Let's say a patient tells you their world starts spinning every time they turn their head. That right there is a big sign that the problem is likely in the vestibular system, that network of balance organs in the inner ear.
Right, it's all about those inner ear structures. So head movements are a big one. What else can tip us off?
Sometimes, even things that don't seem related to balance can trigger vertigo. Coughing, sneezing, straining, or even loud noises.
Wow, really?
It's wild, right? These could actually point to something called paralymphatic fistula, basically a tiny leak in the inner ear.
Huh, that's so specific. Okay, so head movements, those exertion triggers.
Yeah.
Anything else?
Ever have a patient tell you they get dizzy in elevators or just watching traffic go by? Those stop-and-go movements can sometimes signal damage to the otoliths, those tiny crystals in the inner ear that help us sense gravity.
I had no idea that those otoliths were so sensitive. It's amazing how much we can learn from just asking about these seemingly simple triggers. Now, of course, we can't forget about those red flag symptoms we mentioned earlier, the things that should make us think, uh-oh, this could be serious.
Absolutely. Those red flags need to be on our radar at all times. So let's say a patient with vertigo also mentions things like double vision, difficulty speaking or swallowing, weakness or numbness, especially on one side of their body. What do those red flags make you think of?
Those are serious neurological symptoms, so I'd be worried about a possible stroke in the brainstem.
Exactly. That's a situation that needs urgent attention. And what about sudden severe neck pain?
Oh, right. That could be a sign of vertebral artery dissection, a tear in the lining of an artery in the neck.
Ah,
Another red flag for sure.
you're sharp. Now, what if the patient mentions problems with their hearing along with the vertigo?
Well, sudden hearing loss, that ringing in the ears, tinnitus, or a feeling of fullness in the ear, especially if it comes on with the vertigo, would make me think there's a problem within the inner ear itself.
Spot on. Those ear-related symptoms definitely warrant further investigation. And last but not least, let's not forget about headaches. They can be a big clue too.
Oh, right. If someone with vertigo also has a headache, especially if it's that throbbing, one-sided kind that makes them sensitive to light and sound, it makes me think about migraine as a possible culprit.
Exactly. Headache is often a key part of the migraine puzzle, but sometimes the vertigo can be so prominent that it overshadows the headache itself.
Okay, so we're keeping a close eye out for neurological symptoms, neck pain, ear problems, and headaches. Those are our big red flags. Now, I know there's more to the physical exam than just talking to the patient, right?
Right. We've covered so much ground just with the history, but the physical exam is where we really start to piece everything together. And one of the most important things we look for is nystagmus.
Nystagmus, those involuntary eye movements.
You got it. Those dancing eyes can tell us so much about what's going on.
I remember learning about it in med school, but a refresher would be great.
Think of nystagmus as those rhythmic jerks of the eyes, right? They can move side to side, up and down, or even in a rotary motion. And here's the fascinating part. The direction and the pattern of that eye movement can give us huge clues about where the problem is coming from.
Ah, so it goes back to that distinction between central and peripheral causes of vertigo.
Exactly. Let's say you're examining a patient and you notice their eyes are doing that classic side-to-side horizontal nystagmus. And when you ask them to focus on your finger, the nystagmus calms down a bit. What does that tell you?
Well, if the nystagmus gets better with visual fixation, that suggests the problem is probably in the peripheral vestibular system, like the inner ear.
You nailed it. It's like their eyes are trying to compensate for the wonky signals coming from the inner ear. But now imagine this. You see a patient whose eyes have a vertical nystagmus, or their eyes are doing that purely rotational movement. And no matter how hard they try to focus, the nystagmus just keeps going.
Okay, that sounds more ominous.
It is. That kind of nystagmus, the kind that doesn't get suppressed by visual fixation, is a big red flag. It suggests the problem might be central, meaning it's originating from the brain itself.
Okay, so the direction, the type of movement, and whether it's suppressed by fixation. These are all key things to pay attention to when we're observing nystagmus. This is so helpful. Now, are there specific tests we can do to sort of bring out nystagmus and help us pinpoint the cause?
There are, and they're surprisingly simple to do, even in a busy clinic setting. One of the most useful is the Dix-Hallpike maneuver.
Ah, the Dix-Hallpike. I've heard of that one. Isn't that the test where we quickly lie the patient back with their head hanging off the exam table?
You got it. We're basically trying to dislodge those pesky otoliths that might be floating around on the wrong part of the inner ear, triggering the vertigo.
Right. And if that maneuver triggers that upward rotating nystagmus, we can be pretty confident it's BPPV.
You bet. It's a pretty reliable sign. Another great test for assessing the vestibular system is the head impulse test, or HIT.
HIT. Okay, that rings a bell too. Remind me what that involves.
The HIT is all about testing the vestibulo-ocular reflex, or VOR. It sounds fancy, but it's basically the reflex that keeps your vision steady while your head is moving.
Right, like when you're reading a sign while walking down the street.
Exactly. So for the HIT, we ask the patient to focus on a target, like your nose, and then we quickly turn their head to the side. If their VOR is working properly, their eyes should stay locked on your nose.
But if their VOR is off,
If there's a problem with the vestibular system on that side, their eyes will briefly drift off target, and then they'll have to make a corrective jerk to get back on track.
so if their eyes can't keep up with the head movement, it points to a problem in the inner ear or vestibular nerve.
Precisely. And the HIT is particularly helpful for picking up issues like vestibular neuritis, that inflammation of the vestibular nerve.
Wow, the HIT sounds like a real game changer. Are there any other bedside tests for vertigo that we should be familiar with?
There are a few more specialized ones, like tests for skew deviation, ocular tilt reaction, and head shaking nystagmus. But honestly, the Dix-Hallpike and the HIT will get you pretty far in most cases.
Okay, so we've covered a lot of ground on the physical exam maneuvers. But what about those diagnostic tests? When do those come into play when we're evaluating a patient with vertigo?
That's a great question. Brain imaging, like an MRI or a CT scan, becomes really important if we suspect the vertigo is coming from the brain itself, what we call a central cause.
Right, so we're worried about a stroke, a tumor, or multiple sclerosis.
Exactly. Those are the situations where imaging is crucial. What other tests might we order? Well, ENG and VNG can be helpful for really digging deep into nystagmus. They give us super precise measurements of those eye movements, which can help us figure out what's going on. And then, of course, there's audiometry.
Audiometry, so hearing tests.
Right. Audiometry is essential when we suspect conditions like Meniere's disease, which often involve hearing loss along with the vertigo.
Okay, so brain imaging, if a central cause is on our radar, ENG, VNG for a closer look at nystagmus, and audiometry to assess hearing. It sounds like we have a pretty solid toolkit for investigating vertigo. Now, I'm really curious to hear how we can put all of this knowledge together in a practical way. When a patient actually walks into my clinic complaining of dizziness, where do I even begin?
That's the million-dollar question, right? How do we take all of this information and apply it to those real-life situations? That's what we'll be diving into next. All right, so we've talked about the background, the questions to ask, and what to look for during the exam. We know when to hit that panic button. Now let's get to the fun part. Putting all this together to solve real-life vertigo puzzles. You ready to test out those diagnostic skills?
I'm ready. Hit me with a case.
All right, picture this. A 65-year-old woman comes into your clinic and tells you she's been having dizziness. She describes it as this brief spinning sensation, just a few seconds at a time. And it always happens when she rolls over in bed or tilts her head back to look up. Been going on for a few weeks now, but no changes to her hearing, no ringing in her ears, and no other neurological symptoms. What are you thinking?
Okay, so we've got a 65-year-old woman, short episodes of vertigo triggered by specific head positions,
Yeah.
and no other red flags popping up. I'm already leaning towards BPPV. What do you think?
You're on the right track. The short duration, those classic positional triggers, and no other warning signs. It all points to good old benign paroxysmal positional vertigo.
So to confirm, we do that Dix-Hallpike maneuver, right?
Exactly. Remember, we're looking for that upward and torsional nystagmus. The eyes are beating upward and slightly rotating towards the affected ear.
Got it. And if we see that telltale nystagmus, we can feel pretty good about diagnosing BPPV.
Absolutely. And the best part, BPPV is often easily treatable. You can do it right there in your office with the Epley maneuver.
Ah, the Epley maneuver. That series of head movements to guide those little occulifts back where they belong. Feeling like a vertigo detective already. Ready for another case.
Bring it on.
All right, this one's a bit different. A 40-year-old man comes in with sudden, really severe vertigo that just started yesterday. He says the room is constantly spinning. He's been nauseous, vomiting, just feeling awful. No hearing loss, no tinnitus, no other neurological symptoms, he says. This one sounds more intense.
Definitely more intense. Sudden onset, persistent vertigo, nausea, vomiting. He's definitely miserable. What's your gut telling you?
Well, with that acute onset and how severe his symptoms are, I'm thinking vestibular neuritis, that inflammation of the vestibular nerve.
I agree. Vestibular neuritis is high on the list. But,
Yeah.
here's where we need to be extra careful. With such a sudden and severe onset of vertigo like this, we can't rule out a stroke, especially in the cerebellum.
Right, because a stroke, a central cause can sometimes look a lot like a peripheral problem, like vestibular neuritis. So how do we tell them apart?
A meticulous neurological exam is key here. We've got to be super thorough looking for any signs of neurological dysfunction. Remember that hints exam we talked about?
The hints exam, right. So we're doing the head impulse test, looking for nystagmus when they shift their gaze, checking for skew deviation. What are we looking for specifically?
If that head impulse test is abnormal, meaning their eyes can't keep up with the head movement and the rest of the hints exam looks normal, that points us towards vestibular neuritis.
But if any part of that hints exam is pointing towards a central problem, or if there are other neurological red flags, we need to get that brain imaging ASAP, right, to rule out a stroke.
You got it. Better safe than sorry, especially in these cases.
Absolutely. So let's say our 40-year-old patient has an abnormal head impulse test, but the rest of the hints exam is normal, and we're confident it's not a stroke based on his history and the exam. We'd probably treat him symptomatically, right? Vestibular suppressants and antiemetics to help with the spinning and the nausea.
Exactly. You're thinking like a pro. We might even consider a short course of corticosteroids to help reduce the inflammation and speed up his recovery.
Got it. Okay, I think I'm ready for case number 3.
All right, let's hear it.
All right, we've got a 35-year-old woman who's been getting these recurring episodes of vertigo. They last for hours. The vertigo always comes with this pounding headache, nausea, and sensitivity to light and sound. She also mentions that sometimes she sees flashing lights right before the headache starts.
This is ringing a bell. Headache, nausea, light sensitivity, visual auras. Sounds like our old friend migraine is back.
That's what I was thinking too. But here's the thing that threw me off at first. She said vertigo was her main symptom, not the headache.
Ah, that's the tricky thing about migraine, right? It can show up in so many different ways. And for some people, the vertigo is the main event, even more noticeable than the headache. We call that vestibular migraine.
So it's still a migraine at its core, even though the vertigo is the dominant symptom.
Exactly. And just like with other types of migraine, the key to managing vestibular migraine is figuring out and avoiding those triggers, keeping a regular sleep schedule, and finding healthy ways to manage stress.
Right, those lifestyle modifications are so important. What about medications? Do we treat vestibular migraine the same way we treat other migraine subtypes?
For the most part, yes. For acute attacks, triptans or antiemetics can help with both the headache and the vertigo.
And if she's having frequent or really severe episodes, we might think about preventative medications, right? Like beta blockers, antidepressants, or anticonvulsants, just like we would for other types of migraine.
You nailed it. This case is a perfect example of why we need to keep migraine in mind when someone presents with vertigo, even if the headache isn't taking center stage.
This is so helpful. I'm definitely going to be more aware of that from now on. Okay, ready for our last case.
Lay it on me.
All right, we've got a 50-year-old man who comes in complaining of episodes of vertigo, but he's also got hearing loss and this feeling of fullness in his ear. The episodes tend to last for several hours, and he says he also gets ringing in his ears during the attacks.
This one narrows things down quite a bit. That combo of vertigo, hearing loss, and tinnitus really makes me think about Meniere's disease.
I was thinking the same thing. It's like a classic presentation, isn't it?
It is. That triad of symptoms is practically a hallmark of Meniere's. What else would you want to ask him?
Well, I'd want to dig into the specifics of his episodes a bit more. How often they occur, how severe the vertigo gets, how much it's impacting his daily life. And of course, I do a thorough ear exam and order an audiogram to formally check his hearing.
Excellent. Now, when it comes to managing Meniere's, where do you start?
Well, since Meniere's is thought to involve fluid buildup in the inner ear, I'd probably focus on lifestyle changes to help regulate that fluid balance.
Like what?
Things like reducing salt intake, cutting back on caffeine and alcohol.
Those are all great. And we might even consider prescribing diuretics to help get rid of some of that excess fluid.
Makes sense. Now, what about medication specifically for those vertigo attacks?
Vestibular suppressants and antiemetics can definitely help ease the spinning and nausea during an acute episode.
Are there any other treatment options for Meniere's that we should be aware of?
If the symptoms are really severe and haven't responded to the more conservative approaches, there are some more invasive options that an ENT specialist might consider.
Oh, like what?
Things like intratympanic injections of steroids or gentamicin, which can help reduce the vertigo. And in very, very rare cases, surgery might be an option, like to decompress the endolymphatic sac or even to destroy the vestibular apparatus on the affected side.
Wow. Okay, those are some serious interventions. Sounds like managing Meniere's can be a real challenge.
It can be, for sure. But with a thoughtful, personalized approach, we can often help patients find some relief.
Okay, we've made it through all 4 cases. I feel like I've learned so much. Before we move on to the final part of our deep dive, I'm curious, from your perspective, what are some of the biggest traps GPs fall into when they're evaluating a patient with vertigo? What are those common mistakes we should be trying to avoid?
That's a great question. You know, even seasoned clinicians can sometimes get tripped up by vertigo.
Hmm.
One of the most common pitfalls is not taking a detailed enough history. I can't stress enough how important those details are. The tempo of the vertigo, those triggers, those are golden nuggets of information.
You're so right. We can't just rush through the history. What else do we need to watch out for?
Another common mistake is jumping straight to ordering imaging studies without first doing a thorough neurological exam. Remember those bedside tests we talked about? The Dix-Hallpike, the HINTS exam. Those can give you so much information. Often, they'll help you avoid unnecessary and costly imaging.
So using our clinical skills to guide our decisions, not just going straight for the high-tech tests.
Exactly. And don't forget to always keep migraine on your differential, even if the headache isn't the main complaint. Vestibular migraine can be sneaky, remember?
Right, those sneaky vestibular migraines. Any other pearls of wisdom before we wrap things up?
I think the most important thing to remember is to approach each patient with curiosity. Listen closely to their story, ask those key questions, and trust your instincts. You've got this.
All right, we've covered so much about vertigo. Everything from the basics to those really complex cases and even treatment strategies. But before we wrap up this deep dive, I keep thinking about something. We've talked about all these, fancy tests and maneuvers. But as a GP, I'm often feeling the pressure of time, right? Limited time, limited resources. So how can I confidently diagnose what's causing vertigo in most of my patients?
It's a great question, and it's something that every GP faces in their practice, right? The good news is you can usually get to the right diagnosis with just a few key things. Careful history taking, targeted physical exam maneuvers, and a healthy dose of, well, just clinical suspicion.
Okay, let's break those down, starting with the history. What are the most important questions to ask?
Always start by clarifying what kind of dizziness we're dealing with. Is it really vertigo, that spinning sensation, or is it something else? And then zero in on the tempo. How long do those episodes last? We're talking seconds, minutes, hours, even days. This is a huge clue, remember?
Right, the tempo. It helps narrow down the possibilities so much. What else should I be asking about?
Triggers. What brings on the vertigo or makes it worse? Head movements, position changes, coughing, exertion, loud noises. All of these can give you really valuable clues.
Okay, tempo, triggers.
Yeah.
Got it. Now, what about those red flag symptoms? How do I know when to really worry?
Yes. Be on the lookout for those red flags. New severe headache, double vision, slurred speech, difficulty swallowing, weakness, numbness, focal neck pain. These are not something to ignore.
Right. Those could be signs of a stroke or another serious neurological issue.
Exactly. Okay, now let's talk about the physical exam. Even when you're short on time, a few targeted maneuvers can give you so much information.
Like what? What should I be doing?
The Dix-Hallpike maneuver is a must for any patient with episodic vertigo that's triggered by head movements. It's quick, it's easy to do, and if you see that classic nystagmus, you've got your diagnosis BPPV.
Right, and then we can often treat it right there in the office with the Epley maneuver.
Exactly. Another essential tool is the head impulse test. It takes just a few seconds, and it's super sensitive for finding those peripheral vestibular problems.
So with just those two maneuvers, I can already rule in or out some of the most common causes of vertigo.
You got it. And of course, don't forget a good basic neurological exam just to check for any other deficits.
Okay, history, targeted maneuvers, neuro exam. But what about that clinical suspicion you mentioned?
Ah, yes. This is where your experience comes in, right? Your pattern recognition skills. If a patient comes in with recurrent episodes of vertigo and they've got a headache, nausea, light sensitivity, even if the vertigo is the main symptom, always think migraine.
Oh yeah, those vestibular migraines. They can be so tricky.
They can, and always keep Meniere's disease in mind if you see that classic triad: vertigo, hearing loss, and tinnitus.
Okay, I'm definitely feeling more confident already. So even in a busy primary care setting, I can usually get a pretty accurate diagnosis using these straightforward tools.
Absolutely. And once you've got a good working diagnosis, you can decide what to do next, right? Do you need more tests like audiometry or brain imaging, or can you manage the patient on your own?
This has been amazing. I feel like I've learned so much from this deep dive. What's the one thing you want our listeners to take away from all of this?
I want them to remember that vertigo might seem really complicated, but it's often very manageable. With a systematic approach, focusing on those key historical features and mastering those simple bedside tests, you can confidently diagnose and treat most vertigo cases you'll see in your practice.
So well said. Well, that's all the time we have for today's deep dive into vertigo. We hope you found it insightful and helpful. And remember, knowledge is power, especially when it comes to those tricky diagnoses. Until next time, keep those brains curious and those stethoscopes swinging.